Good afternoon, everybody, and welcome. I'm Sarah Dash. I'm with the Alliance for Health Reform, and we'd like to welcome you to today's briefing. We are going to talk today about the Medicare Access and Chip Reauthorization Act, or MACRA, which was enacted because everybody was tired of saying SGR. No, just kidding. We are very excited today to have, we have a great panel, and we're going to talk about MACRA and how it fits into the overall shift of physician payment from, as we like to say, from volume to value. And our partners in today's briefing is the Commonwealth Fund, and Rachel Newsom from the fund will be my co-moderator today.
Great. Thanks so much, Sarah. Just want to add my welcome to all of you on behalf of the Commonwealth Fund. Thank you for spending a sunny Friday lunchtime with us. I know that was probably a hard decision to make. But we're really excited about the panel that we've put together and hope that it just kind of helps continue the conversation as you all try to make your way through this really long set of rules and issues going forward. And just to remind you, we are taking questions live on Twitter, so the hashtag is MACRA. So feel free to live tweet from here. This is on the record. This is press, and we will be watching Twitter and taking questions from Twitter as well. So we've got a really great panel and a good lineup. So with that, we're going to do our introductions and get right into it.
Great, thanks. So I'm going to go in order of speakers. First, we will have Elizabeth Mitchell. She is President and CEO of the Network for Regional Healthcare Improvement, and she's going to kick off the discussion by providing us an overview of MACRA and the context in which it sits. And then we are delighted to have Dr. Kate Goodrich. She's Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. Next, Timothy Ferris, who is Senior Vice President of Population Health Management at Partners Healthcare. And finally, Ashley Thompson, who's Senior Vice President of Public Policy Analysis and Development at the American Hospital Association. So we're delighted to have all of you here, and without further ado, we'll kick off the conversation. Thank you.
Thank you, and thank you for having me. This is a very hot topic across all of my members across the country. But I want to start with sort of taking us back. So imagine it's 1983, Madonna's first album just comes out, and we are about to implement DRGs. DRGs are the most significant change in health policy since the inception of Medicaid and Medicare. And they really did not have their intended effect. You know, from clinical perspective, we had shorter lengths of stays that may or may not have been appropriate. We actually increased cost. So here we are on that same precipice where the largest purchaser of healthcare in the world is about to shift trillions of dollars around to hopefully achieve better care at lower cost. And not just shifting payment, but we're going to be talking about changing some of the fundamentals of care delivery and data sharing and some of the basics of the healthcare system as we know it. It will not go unnoticed. And it will change the market. But I would suggest that whether or not it changes it successfully is really up to all of us. And it is going to take all stakeholders working together. And I think some of the key elements for success for this new environment are going to be regional data sharing, effective quality improvement and technical assistance support, particularly to small practices, and multi-stakeholder and multi-payer alignment. So I'm going to talk briefly about that. So I want to just remind, oh, I have a clicker. I want to just remind us why we're here. We do actually have a problem with health spending in the US, and I work at the regional level with communities, and most people don't think in GDP, but they are thinking about 10 years of wage growth being absorbed by healthcare costs. I work with unions who haven't had a raise in 5 years, or personal bankruptcies, families who can't afford care, or my personal experience where my daughter's middle school had to cut sports to pay for the increases in teacher premiums. So we are challenging health investments with some of our spending. But even more importantly are some of the continued quality failings. Since the IOM released, Crossing the Quality Chasm, however many years ago, we have not made progress in closing those quality gaps. So we've got to deal with both issues. And it will take redesigning care delivery and incentives, and I think MACRA is really trying to get at removing some of those barriers to optimal care. So one of the most significant aspects of MACRA to me is that it was bipartisan. We actually have bipartisan legislation. And I think it will likely be more impactful even than the ACA, because it is really going at the fundamentals of delivery and payment. And I actually don't think it's going to go away, A, because it's so bipartisan, and B, because it is so complex, I don't know that people would know where to start. So I think that we are going to be living with MACRA for a long time, and again, it is up to us to make it successful. So again, this is very, very basic. We're repealing the sustainable growth rate, but I will say that in communities around the country, there are a lot of physicians and practices who think that's it. The SGR goes away and we're done. That is absolutely not the case. And bringing those practices and communities along with some of the new programs, the new requirements, is going to be essential. And I think that's one of our biggest challenges, is that communication and engagement. So it changes payment, and it actually streamlines multiple quality programs, and luckily Kate Goodrich is here to explain all of the technical detail of that. And it provides bonus payments for participation in advanced APMs. It is clearly part of a much broader push to improve value and quality. And one of the things that is most notable about this work, from what I've experienced from CMS, is the multi-stakeholder involvement. We know that this is not just going to happen from Medicare. It's going to take commercial payers, employers, all the stakeholders have to do this together, because practices don't change care for a single payer, even if it's Medicare. We've got to get alignment across the market. And there are groups like the Healthcare Payment Learning and Action Network that are working on that. So they've come up with this elegantly simple model, moving from fee-for-service to population-based payment, which sounds great. But we really need to realize that moving from fee-for-service, all of the operational aspects of fee-for-service might be completely different under population-based payment. And the goal would be, according to the land, to shift from that one bubble, which is fee-for-service now, over years to go to the dominant payment being episodes and population-based payments, so that practices and systems can be accountable for total health and total cost. So that might sound easy on a slide, but we are talking about truly changing the fundamentals. What information do you need to be able to do this? What team members do you need to have to be successful? How do you connect with the community? So, I was working with a cardiologist who said he finds himself in a bundle, and for the first time, he is driving around to the local nursing homes, because suddenly their fates are tied, their payments are linked. So it's going to take new relationships across communities, new information sharing. How do you track a patient across settings, across providers? We've got to really get to the fundamentals to make that successful. So again, one of the easier changes maybe is aligning existing programs into a current program, sort of a single program called MIPS. And again, I will defer that to Kate to explain. But this is building on some fairly complex programs and hopefully simplifying them, making them streamlined, making them actually easier to participate. But one thing that is really important to keep in mind is that this is budget neutral. So there will be increased payments for some practices based on their performance, but because it is budget neutral, there will also be decreased payments for others. And we're going to have to monitor what impact that is having on what practices, what specialties. But this is a major shift. We are really tying payment to performance. This is just a quick snapshot. We're looking at the multiple pathways. I actually won't spend any time on that. But what is important, I think, for practices is to understand that the performance year one, where your payment will start to count, is 2017, and that the payment for your performance in 2017 starts in 2019. So this is not far away. This is, we are talking about performance that we will need to be really paying attention to within the next several months. So this is going to start to have a sort of a delayed impact, but really important that the communities and the physicians in the communities really understand that this is coming. Again, this is going to be sort of a combined program of measurement. We're going to be looking at quality and a lot of the quality measures that we've had in place from existing programs, but we're also really introducing and amplifying the importance of resource use. Are we effective stewards of resources? And again, that goes to really managing total cost of care. There will also be credit for clinical practice improvement activities, participation in a patient-centered medical home will get full credit for that. But there's also a whole menu of options where you get credit for participating in a practice improvement activity. And then really new approaches to sharing data and really making sure that interoperability is a real thing. And we're not actually going far from meaningful use, but we are hopefully making it more effective for actual outcomes. And one other thing that is of note is that the weighting of that resource use score does go up over time. So we're starting with 10%, which I think is a fair place to start, but over time that starts to be more and more of the score, so it will be more and more important for physicians and practices and systems to be able to effectively manage. So this is how you get to be an advanced APM. Again, there are MIPS, then there's APMs, and now advanced APMs. And I would just focus on the biggest distinction to become an advanced APM is taking downside risk. And so what that means is there are multiple programs, but many of them, even though there are lots of participants, aren't going to qualify as advanced APMs. So I think we're going to see ACOs who came on in the track 1 of MSSP, realizing that they're going to have to change course to actually qualify for the biggest incentive payments. And this is going to be tricky. So imagine you're a provider in the field, and you, first of all, how do you qualify for the advanced APM payments? First, you have to know this is happening. So we've got a lot to do to actually engage them in this dialogue. Then you need to choose a program that qualifies. Then you have to be selected by CMS to participate in that program. And then you need to meet the required thresholds of patients, which is 20%, and payments, which is 25% to qualify. So it's doable, but it is very ambitious. And again, it is going to take a lot of engagement and support in the field. So I have just a few minutes left, and I want to just make sure that we don't forget the new PTAC. Both Tim and I have the pleasure of serving on the PTAC. It was created by, within MACRA, we're appointed by the GAO to actually look at alternative physician-focused payment models. So we will be hearing from the field and engaging with providers in the field to really understand what are the optimal payment models that will achieve the outcomes that we're all looking for. We will be evaluating their submissions of proposals, and we'll be offering some general technical assistance, and we will be recommending these to the Secretary for inclusion. So there's lots of ways to enter the program, and this is a really important new door for physicians to bring alternative models to the field. So I want to just do really quickly look at one slide that I know has gotten some attention. There is some estimated impact of MIPS by practice size. And I want to just, first of all, qualify this. This is old data. This is, we don't even think that this is still accurate. We know that performance and against these criteria have improved. But what this calls out to me is the need for technical assistance and support in the field. So we've got to make sure that the practices have the data they need, the quality improvement tools, and support to be successful, because no one is looking to disadvantage any practice, particularly those who are doing great patient care. It's really about connecting this policy to on-the-ground support.
Thank you. Okay, is it, okay, it is on, good. The light I can barely see. All right, well, thank you for having me for this panel. I'm excited to give you what will actually be a fairly high-level overview of what we are calling the Quality Payment Program, which encompasses both MIPS and alternative payment models that Elizabeth spoke of. So we are looking at the Quality Payment Program as really a first step to a fresh start. And the reason we're doing that is we had these 3 existing programs: meaningful use, the Physician Quality Reporting System, and the Physician Value-Based Payment Modifier, that have been in play, some longer than others, and aligning them on the back end for us at CMS was quite challenging. And we know we've learned a lot from the listening that we've done to clinicians and our experience with implementation about what has worked, but more importantly, what has not worked well. And there's a lot out there that hasn't worked well. So we really saw this as a marvelous opportunity to just really kind of start over. But we wanted to take from what we knew was working as well. As Elizabeth pointed out, we've done a lot of stakeholder engagement. The law required us to do that, but we felt like if we really were going to take a fresh start, that it couldn't just come out of our heads. We really had to spend time in the field, in doctors' offices, in nurse practitioners' offices, learning where their pain points are. So we've done a lot of listening and tried really hard to craft our policies, but also our communications, how we're building our IT infrastructure to really meet the needs of clinicians where they are. And this is really important because Medicare as a program, we cover between Medicare and Medicaid CHIP and the marketplace, we cover about 140 million Americans, right? And more Americans are going to need these programs as time goes on. And so we have to have a sustainable, smarter, healthier Medicare, and we see MACRA as a really important tool in getting to a sustainable Medicare. So we've got to be paying for what works. We cannot pay any more for what doesn't work, and we can't waste our precious dollars. And then I think a very important component of this is ensuring that health information is open, flexible, that clinicians can use it at the time that they need it, and that it's available to patients when they need it, and in the form that they can understand it and actually use it. And so with those sort of principles in mind, we have put forward our proposed policies for the merit-based incentive payment system, or MIPS, and advanced alternative payment models. In the MACRA legislation, they're called eligible APMs. So we think advanced reflects a little bit better what they are. So just briefly, what is an APM? The law actually sets out the criteria for what an APM generally is, and it says it's either an innovation center model, the Medicare Shared Savings Program, which is not an innovation center model. It's a separate national program, and then a couple of different types of demonstrations that are authorized by law that are less common than the first two categories. And then MACRA went further to say, okay, what exactly is an advanced APM? What are the specific criteria? And so to be an advanced APM, and this is critical because advanced APMs are where you can be a clinician and not be subject to MIPS, right? So that's why this is really important. So an advanced APM, clinicians in advanced APMs have to be using certified EHR technology, number one. They have to base payment on quality and quality measures that are comparable to those that are in the MIPS program. And they have to either require downside financial risk, or what's called more than nominal risk in the legislation, or they can be a medical home model that is expanded under CMMI authority. So if a model does not meet those three criteria, then they are not an advanced APM. But of course, we had some latitude within our regulation to make proposals under each of these. So I'm going to touch on a few topics that I think are of most interest to most audiences. And so I'm not going to walk through every detail because it is, I think, 963 pages, and that's just a lot to do in 10 minutes. So one of the criteria, of course, is that APM entities must bear more than nominal financial risk. And I'm not going to get into the details here, but basically what we said was that advanced APMs have to meet two standards. First is a financial risk standard where they must bear risk for monetary losses, and then the second is the nominal amount standard, which is the risk that they must bear have to be of a certain magnitude. So we made proposals around what that magnitude is. And so the advanced APM criterion are met completely if, again, it's an expanded medical home model, expanded under CMMI authority, and that if there are models that are not expanded under that authority, they will have different financial risk and nominal amount standards. So within an advanced APM, if you're a doc or a nurse practitioner or other clinician that works in an advanced APM, how do you know if you are exempt from MIPS and have the opportunity to receive the bonuses that come with being in an advanced APM? So you have to meet certain thresholds, and Elizabeth touched on this as well. In order to be what's called a qualified participant in an advanced APM, you have to have a certain percentage of your payments or patients come through that advanced APM. And again, we made proposals around that, although some of that actually is set in the statute. So the 25% threshold of payments is set in the statute. And by the way, that goes up to 50% in 2 years and then to 75% after that. So it is aggressive. It's definitely a high standard. So if you are a clinician who meets that threshold and you are participating in an advanced APM that meets those 3 criteria, you are excluded from MIPS and you receive a 5% lump sum bonus, and this is available every year for 5 years. And then after that, the physician fee schedule updates bifurcate. So it's higher if you are a qualified participant in an advanced APM starting in 2026, and it's a little bit lower if you don't meet those criteria. We do know that certainly in the first year and probably in the first couple of years that the majority, a significant majority of clinicians will be subject to MIPS. So we think that most folks are not yet in an APM, and by 2017, while there hopefully will be more that are in APMs, that the majority won't be. And if they are in an APM, it may not be an advanced APM. And if they are in an advanced APM, they may or may not meet the threshold. So we know that, again, most folks will be subject to MIPS. So our goal was to really design the MIPS policies in a way that would prepare clinicians to be able to meet the requirements of APMs and be able to easily, or somewhat easily, transfer or move into APMs over time. And one thing I want to point out that people don't always realize is that actually, if you're in an APM, whether you're advanced or not, you are generally held accountable for the same 4 things that MIPS holds you accountable for. You're accountable for quality measures, you're accountable for cost, albeit maybe measured differently, so total cost of care, you have accountability for that. You have accountability for improvement activities. All of the CMMI innovation models require improvement activities, and you're accountable for use of EHR. So it really is the same 4 things. So let's go to MIPS. Again, first step to a fresh start is how we really thought about this. Streamlines the 3 programs that I mentioned, and it does add a 4th component. So the 3 programs, of course, were centered around quality, cost, and use of EHRs. Now we have the 4th component, which is clinical practice improvement activities. I think Congress recognized that there was a lot of great improvement work going on out there, and that people should get credit for that, right? And as we've actually gone around the country and listened to what people are doing, we've seen that. One of the other things we really tried to do, and you guys and our commenters will have to tell us if we did this, is we really tried to provide flexibility for clinicians within the MIPS program so they had different choices that they could make around quality measures and how they use their EHRs and so forth. What you sacrifice with a lot of flexibility is simplicity. And so this is a complex regulation. It is a complex program. But I just wanted to point that out as well. So the rule has 4 major provisions, the 4 categories. Let's see, you stole my slides. That are under MIPS, so I won't go over those again. This is the first year, the category weights, which Elizabeth also touched on. As Elizabeth pointed out, the final composite performance score is based upon performance in each of those 4 categories. We did make some changes from the existing programs. For example, under quality, we require under the current programs that clinicians report 9 measures of certain types of measures across 3 national quality strategy domains. We've reduced that down to 6 measures because we've heard from a lot of people that they don't have enough measures available to them, and we know that's true. We have, of course, resource use. We have currently about 3 what are really total cost of care measures, global total cost of care, as well as some around CHF, chronic obstructive pulmonary disease and diabetes. We actually are proposing 40 different episode-based measures to address specialty gaps, although it doesn't cover everything. And then clinical practice improvement activities, we do have an inventory of about 90-something improvement activities, again, from what we learned across the country. People are actually doing and implementing, and that is working for them, that people can choose from. And then advancing care information, which is around use of electronic health records. We did a few things there that I'm going to focus on next because I know there's a lot of interest in this particular category. So in the current meaningful use program, clinicians, it's sort of all or nothing, as people know, where you have to meet certain thresholds for every single measure in order to meet meaningful use. And we've heard from a lot of folks that the practice of medicine is so varied, having it be all or nothing and requiring people to all do the same thing just doesn't make sense for their practices. And so we really wanted to provide more flexibility so people could really choose and focus on the measures that are most meaningful to them. So that's what we did here. So we also eliminated a couple of measures that we knew were topped out and that were kind of burdensome. Computer order entry and clinical decision support. Still required to be part of certified technology, but not required to report to CMS. And then, of course, we reduced the number of required public health registries. We heard from folks that reporting to 3 or 4 registries really was difficult for some clinicians to have to do. So now we require a single registry, but you get bonus points if you report to more. This is really a significant change in the structure of meaningful use. What I will say is the measures are essentially the same as what we finalized in stage 3. We know there is a desire to move to measures that really reflect patient outcomes related to the use or a safe use of EHR technology. We agree that is the goal to get there. And so there is some work that the Office of the National Coordinator is doing in partnership with a lot of different stakeholders to identify different types of measures and standards for being able to measure outcomes, say around care coordination and closing the referral loop and how you actually engage patients in care. So measures that are maybe not so process-focused as the ones that have traditionally been in the program. The other thing to note about this category, while the weight is 25% as outlined in statute, we do have the flexibility to downweight it to as low as 15% over time, the more and more clinicians that are meeting the requirements for advancing care information that come on board. And I think we're going to get there pretty soon because currently under the Meaningful Use Program, we know about 74% of clinicians are in fact meaningful users. And the threshold that's in statute that allows us to downweight this category is once we get to 75%. So we think we're obviously pretty close. And then a couple of words about small practices. This is a segment of the clinician population that was very much at the top of our minds as we were designing the rule. The law is complex, I think in many ways necessarily so. So the complexity is a little bit hard to get around, and we need comments from the public about how we can simplify in almost any area. But we really were thinking about, for every policy that we came up with, we were really thinking about how does this actually affect the individual solo practitioner, or how is this going to affect a small practice? And are there certain provisions that we have the authority to put in place to treat them maybe a little bit differently if possible as they sort of get on board? So certainly one of the exclusions from MIPS is if you have a low volume of Medicare expenditures or Medicare patients. So we think actually a lot of small practices probably are going to meet that low volume threshold and will not be subject to MIPS. Again, we did try to reduce the burden as well as adding some flexibility in the MIPS categories, clinical practice improvement activities. If you are a group practice of 15 or fewer or in a rural area, you're required to meet 2 activities to get full credit for that category. Whereas everybody else has to meet 3. So that's one change. We also have the flexibility to re-weight the categories for MIPS. If you don't have measures that are relevant for your practice, we can actually downweight that particular category to 0, and we'd have to upweight something else. So that's another provision within the legislation. One of the things that's in the legislation is that we can develop a process for people to nominate to be virtual groups. So practices, for example, as an example, in a region that maybe they coordinate care together to take care of the same population of patients, but they're separate practices, they could self-nominate to be a virtual group to basically submit data together as a virtual group. We weren't able to operationalize that in the first year. That's going to take some thinking about how to do that well, both on the policy side and the operations side. So we are now seeking comment on that. The other really important thing about MACRA that we were very pleased with is the $100 million that's available specifically targeted at technical assistance to small practices, rural practices, practices in health professional shortage areas. We thought this was such a great provision. So we're in the process now of we should be putting out our RFP for that relatively soon so that people can apply to be able to provide that technical assistance. So we're really excited about that. We also already have a major initiative underway called the Transforming Clinical Practice Initiative, an almost $800 million initiative to provide that frontline, boots on the ground assistance to practices to get people in their practices who can actually help them learn how to use data, how to access and use and understand their data and act on it, how to develop different care teams, a variety of different ways that things that one can do to really be successful in transitioning into an alternative alternative payment model. So that's an area that we're very focused on. And then just to build on what Elizabeth said around the regulatory impact analysis that showed that such a high proportion of small practices were really not going to do well under MIPS. Those data were based upon 2014 PQRS and value modifier data. That was a year that small practices actually weren't eligible for the value modifier, and many of them just didn't participate in PQRS, and so they automatically got a downward adjustment because they didn't send in any data. So that's what that reflects. It doesn't reflect a lot of the provisions that we have proposed in our regulation to really target small practices. When we look at the data for those who did participate, their performance on quality measures, they actually perform very comparably to medium and large practices as well. But we still, having said that, I don't want to minimize that this is going to be difficult for individual docs and small practices, and that is really where we know that we need to focus our efforts, but we need the help of specialty societies and registries and regional collaboratives and all other types of folks who work in the healthcare space to help these practices succeed. This is very similar to what Elizabeth showed you, just sort of the years that we have the up and down payment adjustment. Please note that for the first year, 2017 performance, which relates to 2019 payment, it's scaled between -4% and +4%. So folks will get an adjustment along that linear scale. And also, the other thing to note is that 4% in the first year is actually lower than what any clinician is subject to now. Because with the 3 programs together, clinicians are subject to as high as an 8% adjustment. So this actually lowers it below that for the first 3 years, and then it does end up at 9%. So I know I went over my time. Thank you for giving me a little extra time. I appreciate it. It's a big law. It's a big rule. Love to hear your comments. Thanks.
Great. Thank you. That was really important background.
Good afternoon. So I'm going to start off by saying that I'm a primary care physician, and while I was sitting here listening to Kate, and I do enjoy listening to Kate, but I was also refilling some prescriptions and emailing with my patients. And I wanted to just say that there is a difference in my incentive to do that under these new rules than under a fee-for-service system. In a fee-for-service system, I would do it because it's the right thing to do for my patients, but I actually have a financial disincentive to use this kind of technology for the convenience of my patients because I'm paid only when a patient sees me in a face-to-face visit. I also practice at a hospital that is part of an advanced APM, a pioneer ACO, and therefore I and the 2,000 clinicians who practice with me already have an incentive to incorporate this kind of efficiency and service into the way we deliver care. That's really important. It's a really important benefit to the patients to align the financial incentives with the best technology, the most efficient service. So I'm going to, now that I just was way down at the grassroots level, go really high up and say, so though cost increases have slowed remarkably over the past few years, healthcare costs are still rising at an unsustainable rate. And there are 4 widely agreed upon drivers of those costs. First, the aging of the population. This is actually, when you look at cost projections going forward, this is the largest contributor to the projected federal deficits due to healthcare costs. It is the aging of the population. It is the baby boom getting older and sicker. Second is inflation. This is just normal inflation. So about 50% of healthcare costs are for people who directly deliver care, doctors and nurses. And these people's pay needs to generally increase over time, more or less, at general inflation. Second factor. Third factor is innovation. So there's been a steady stream of new stuff that we pay for. That new stuff in healthcare has been extraordinary. Some of it is literally life-changing, and other stuff adds small, even negligible incremental benefit. Sorting between what is life-changing and what is minimal incremental benefit has been a challenge for the healthcare system, a challenge that I think MACRA in part addresses. And the fourth factor driving healthcare cost increases is providing unnecessary or low-value care because of incentives created under a fee-for-service payment system in a world where there is so much gray so much gray in what is right in medical decision-making, allowing those who deliver care to drift towards providing higher margin care, even if this pattern of care delivery does not optimize the health of the populations getting care. So those are the 4 drivers of healthcare costs in the United States. So the replacement of SGR by MACRA is a step forward because it replaces a flawed mechanical formula with an attempt to deal with the 4th cause of healthcare cost escalations directly, the fee-for-service payment system, and it also indirectly addresses the other 3 causes: illness burden, inflation, and innovation. So I'm going to touch on each of those 4 real quickly. So the aging of the population. The U.S. is facing a looming capacity and workforce crisis. The healthcare needs of the baby boomers is going to overwhelm our current capacity to deliver care as well as our budgets, unless we deliver care differently. Unless we can empty our clinics and hospital beds of relatively low-value care so that there is room for the really ill to take their place. There may be several good reasons why this kind of overhaul should not be left to government regulation, but maybe the most compelling is that the speed with which best medical practice changes dramatically exceeds the speed at which government and regulators can change policy. It's an opinion. Here, MACRA does something very clever. Under the alternative payment models that you've just heard about, physicians, specialty societies, hospitals, and others can propose what value is in their proposals to APMs, to become advanced APMs, right? And if approved, can implement and be paid for those changes. So this is an important step because it actually helps keep the government out of the examination room and say, it's actually the people who are delivering care that are going to be proposing what those changes are that are going to deliver the highest value care. To the extent that these provider design changes make the delivery of care more efficient, this new payment policy will indirectly address the increasing disease burden problem. And remember, that is our biggest cost problem going forward. Second, wages for healthcare workers. So government sources pay 30% of the revenue collected for the care that I deliver as a primary care doctor, but 60% of my patients are insured by the government, are paid for by the government. You notice there's a disparity there. So there's cost shifting at a huge scale in the United States from commercial payers to government payers as a source of revenue for the provision of care. That means that commercial payers are picking up the tab for shortfalls in government spending on health care. This means that U.S. employers are picking up that tab, right? So over the past decade and a half, Medicare rates have not kept pace with inflation. In fact, all in, they're exactly equal to what physicians were getting paid in the year 2000. So while overall healthcare cost increases have been unsustainable, a payment policy that simply reduces payments, locks in current flawed distribution of services, and punishes the undervalued services the most. Here again, MACRA addresses this problem by providing opportunities for upside that are at least in theory more aligned with valued services than the current Medicare fee schedule. A word of caution here. MACRA also has penalties that will necessarily be imposed on 50% of providers, even though the because of the budget neutrality provisions in MIPS, or the potential through the benchmarks that are required for APMs. There's downside on that. So Kate showed a slide that only had the 5% upside on the APMs. To be an APM, you have to take downside risk, and some of those people are going to lose money by definition by taking downside risk. Remember that I previously pointed out that we are facing a workforce problem with the aging of the population. Penalizing physicians who have seen their Medicare income steadily decline relatively may make some sense from a behavioral economics perspective, but purposefully demoralizing a large group of professionals, some, possibly even many of whom are truly dedicated to serving their patients, may not make for great federal policy. This is not a necessary outcome of MACRA, but a possible outcome, So we must be really vigilant as we implement this process. Third, innovation. Presumably, if APMs work as intended, then providers will be more selective in their adoption of new technology and more price sensitive toward vendors of this technology. This will hopefully create a new market for innovations that can actually make healthcare more efficient, like the program that I was just using a minute ago. So no such market pressure existed under a fee-for-service system where providers and technology vendors have been adopting new technology under a system where they both benefited and neither one needed to be overly concerned about the costs. So MACRA has the potential to help our system be a bit more careful about the adoption of new technology and possibly even incent the creation of technology that provides net increases in productivity and efficiency. And fourth, the basic inflationary pressure of a fee-for-service system. I won't go into this because it's obvious how MIPS and APMs are designed to directly improve the value of services delivered by physicians. I will close with a couple observations from behavioral economics that I've learned as the medical director of the largest physicians group in the Northeast. So there are some rules about incentives that I've seen play out at the Mass General Physicians Organization. First, small incentives can go a long way if what you are asking people to do is consistent with what they think is the right thing to do. Again, here I think it was very clever for MACRA to create policies where the providers themselves are actually putting forth the metrics, because by definition, those should be metrics which are aligned with what providers think is the right thing to do. Second, if the performance you are looking for is not under the control of the people getting the incentive, then the incentive will fail. This is a tricky problem in healthcare because healthcare outcomes are not necessarily under the control of the people delivering healthcare. Only a fraction of those outcomes are, or a fraction of attributable outcome. This has befuddled people who have been in the metric business in healthcare for decades, and it will continue to befuddle us. Again, the MACRA rule, by putting it in the hands of the providers, the metrics, does a very clever job of making sure that the metrics are going to be the ones that are acceptable. Third, the time frame for performance to reward needs to be as short as possible. This is a problem for MACRA. You saw a couple slides where it's asking physicians to make investments in infrastructure and change behaviors 2 years before they know about whether or not they're getting a reward or a punishment. That's a problem. And it's going to be a problem that CMS and all of us are going to need to work very hard to try to mitigate. Fourth, complexity. At the physician level, given the work of caring for patients, it's not reasonable to ask for doctors to pay attention to more than a couple new things any 1 year. We have a program, and a physician incentive program, where we run it on 6-month cycles. So physicians learn about their new performance metric. They are, and within 3 months they're measured, and within 6 months they're paid. That's the kind of time cycle that works where I work. And we learned that we really can't ask for more than 3 things in any cycle, because they have a lot to pay attention to already. I want me to be remembering the proper doses of antibiotics and not necessarily a lot of arcane rules in payment systems. We have to be vigilant about that. And fifth, you need to be vigilant about unintended consequences. I have never seen an incentive system that did not produce unintended consequences. On net, I think what MACRA is proposing is, for all the reasons that I've said, is a big advance forward for mitigating some of the problems that we've been dealing with in the fee-for-service system. But it will have unintended consequences, and we need to be vigilant about paying attention to those, predicting them when we can, and remediating them as soon as we learn about them. Thank you. Yes.
Hi. First, I want to thank the Alliance and the Commonwealth Fund for having this session on MACRA. It's really a very important piece of legislation. It's a really important rule that's just come out, and I appreciate they letting hospitals come to the table to share our perspective. So first of all, I'm going to back up a second as well and say that last March, Congress passed this historic legislation. I mean, not only was it bipartisan, it was also bicameral. We don't see a lot of that going on these days, so I wanted to offer my congrats to everyone in the room who might have worked on this legislation, because it was really a huge feat for you to get it across the finish line. AHA supported the legislation for mainly 3 reasons. One is that it provided some stability for physician payment. 2, it provided incentives to move them towards value, something that the hospital field had been doing for some time. And 3, it financed it in a very balanced manner. So what does MACRA do? Well, they finally repealed the flawed SGR formula, the Sustainable Growth Rate formula. This was after 18 years and 17 temporary patches, so it was a huge feat. The cut to docs on April 1st, following the day, it was about a week following the passage of this legislation, was to be 21%, and something like that is not sustainable. And I just wanted to add a personal note that when I was on the Hill, we would work all year trying to find offsets to pay for that billion-dollar plus, multi-billion-dollar fix. And we'd be working so hard, and we'd finally get it across the finish line. We'd get something adopted, at the very end of the year, the Christmas tree package. We'd go home for Christmas and or New Year's if we were lucky, and then we'd come back January 1st. And, January 2nd, God bless them, the doc groups are in our offices saying, okay, well, now we're going to have a cut. What are we going to do to fix the cut? So it was just this cycle that you need to understand that the staff spent so much time trying to figure out what to do, because each time you paid for this cut, you kind of dug a deeper hole, and the cut got bigger and bigger. So really, it was really quite remarkable. Also, it creates a whole new physician payment system. In doing so, I know we talked about the 2 tracks, and I'll talk about it more to the MIPS and the APMs, but both of those really a good thing to move physicians and to move all providers, because it's not just physicians. So, it's physician assistants, clinical nurse specialists, nurse practitioners, et cetera, to a new system, anyone who's paid under the physician fee schedule. And so why this matters to hospitals, given MACRA is so focused on physicians, you might wonder why our almost 5,000 members care about it so much. Well, first of all, physicians and hospitals must really partner together to move towards value-based care. It's really critical that we do this together, hand in hand, with aligned incentives. Secondly, it probably doesn't surprise you that hospitals employ almost 250,000 physicians, and we contract with another group of almost 290,000 physicians. So this really impacts a significant portion of the physicians who practice at hospitals and who interact with hospitals. And then finally, hospitals are subject to their own pay-for-performance proposals, and we've done it for many years, but the ability and the opportunity at this point to align incentives so that we're not focused, and you said the new DRG system, which really created new incentives for hospitals. Now the physicians also have these new incentives that have aligned them towards us so that we can work together on care. I know that we went through kind of these annual payment updates, and you can see there how it provided 0 update, then 0.5%, then 0.5% annually for about a 5-year time period. I know we talked about in 2019 how it sunsets the various payment programs that were currently underway for physicians and created those 2 tracks. Here, this looks very familiar to the slides that Elizabeth and Kate both used, and it shows the payment for the following 5 years. Just wanted to highlight that it is, again, a 0% annual update, and that physicians and other professionals will be relying on either that bonus payment of 5% or the plus or minus MIPS payment, which starts at 4% and grows to 9%. And then also just want to make you aware, at 2026, that bonus payment disappears, but there is a differential payment update for physicians that are in APMs. They get a higher payment update versus those that are in MIPS that get the lower payment update. So what's the impact on hospitals? And this is really why I'm here to talk to you today. You can't underestimate the cost of compliance with all of this and the new measures. I know you've heard about the complexity. I know we focused a little bit about the 1 or 2 solo doc practices, but this is going to be a challenging undertaking, even if they don't, hopefully that they know that it's coming, because I think a lot of doctors don't even know that it's coming. What might happen is that these solo practitioners or those in small group settings might come to physicians come to hospitals asking for employment opportunities. I think there will be a number of physician retirements who just throw up their hands and say, I can't really do this. It also creates pressure for hospitals to participate in these risk-bearing arrangements. Our medical staffs might say, hey, I'm not really thrilled with a possible 9% reduction to my payment. If I'm contracting with you, give me an opportunity of an alternative payment model that I can enter into with you so that I can get a 5% bonus. But it's a huge strategy on behalf of hospitals. Do we want the physicians that we employ to do the MIPS track? If they're really super high-quality physicians, they could get a 9% bonus instead of a 5% bonus. We might want to do that in some cases. Is the unintended consequence possibly that all of our poor-performing physicians might enter into APMs because that protects them? We don't know yet, but it's going to be something that hospitals are going to have to work through as they move forward. In general, I just wanted to give you our overall reaction to the MIPS system. We really want, and we applaud a lot of what CMS did here to work towards a quality payment system that's more fair and focused. They did streamline those quality measures down to the 6 across the 3 categories. I think it is from 9 in the 3 categories to 6. They did, so we applaud that. We want them to go further, though. There's an IOM report out there called Vital Signs that really work towards streamlining quality measures, and we hope that they can look towards that moving forward. There's, on the risk adjustment side, we're worried that some of the measures don't have appropriate risk adjustment. One in particular has to do with SES adjustment or socio-demographic adjustment. You've heard us over and over on readmissions and how that impacts hospitals that serve poor patients or are in challenging demographic areas. And so we want to see some better risk adjustment to the quality measures. The hospital-based physician measure reporting option, what we'd really like to do is allow our employed docs to use the hospital-based measures to kind of satisfy MIPS because our pathologists or anesthesiologists or even the hospitalists that we employ, it might be easier for them to use the hospital-based measures, which will truly align things rather than have to do another set of MIPS measures. And then while there has been some great flexibility related to health information technology, and we appreciate that, we think that the parameters that are in the rule are still too high for most physicians to meet, and the requirements are still requiring docs to do things that they currently can't do. But on that same topic, that flexibility is appreciated, and we hope that hospitals can also see some of that flexibility moving forward. In terms of our reaction to the APMs, we really support as inclusive a definition as possible. This is the way that, the sentiment from my viewpoint is, throw down 1,000 seeds and see where the flowers bloom across the country. And so the more alternative payment models we have, you might say the better. But in this case, while there are a number of current models that aren't going to be included, and that track 1 MSSP, where 86% of people are currently in that one, that's a lot of people who are getting excluded. Currently, there's really just 5 models that you can be in, and no one talked about it, and I won't get the figures right, but it's about less than 90,000 physicians that will qualify, which is really a small number. Hospitals have contributed a lot of investment risk in setting up ACOs. As you know, we're mandated to do CJR that's the hip knee bundle in certain areas of the country, and that isn't included. We have a number of providers that have undergone the BIPSI models. Those are the other bundling models, and those aren't included, so we think that there's a lot of opportunity there. We also have some concerns that many of our members are participating in MA, and for the first 2 years, that might not qualify. For the second 2 years, it might, because it will be external payment, and we hope that that constitutes, because that's pure risk. And then currently, in order for hospitals and physicians to work together, there's a number of regulatory and legal barriers. So there's tax-exempt status issues, there's civil monetary penalties, there's Stark, there's anti-kickback. There's a number of provisions that we'd like to see some changes to really allow hospitals and physicians to work together. And then if we get to the outlook so far, because I'm running out of time too, you can see that there are some things that we think are moving in the right direction related to less measures, the steps to align the measures with the public sector, and we appreciate them using some of the core measures that were developed by CMS, AHIP, and some other insurers, as well as physician groups, so that was very positive. Moving away from the all or nothing in IT was in the right direction, but we don't think it's enough. And you can see the other items where there's some work in progress in some areas that we're concerned, which I think I went through, which is narrow definition of APMs, some of the HIT misalignment, and no adjustment for the measures, especially related to readmissions. And then finally, so you know, our AHA has taken this really seriously. We're trying to educate as many of our hospital members as possible and share with them resources that they can use with their independent medical staffs. So if you go to our website with the link down at the bottom, you can see that we have a number of webinars that help explain this issue, some presentations that you can actually download yourself. They're just PowerPoint slides so that our hospital CEOs or C-suites or medical staffs can use that to educate others, as well as FAQs, timelines, and then, of course, all of the literature that AHA puts out on these. So with that, I will turn it back over. Thanks.
Thank you so much. Thanks to all of our panelists. So now we're going to turn to the more interactive portion of the conversation. You have green question cards in your folders. You could write questions out, hold them up in the air, and staff from either the Alliance or the Commonwealth Fund will grab them and bring them up here. There's also microphones in the room, so you can also just stand up and ask a question in the microphone. And we also have a few questions coming in on Twitter too. So Sarah's going to get us started while you guys pass your questions up and start lining up at the mic.
Great, thanks, Rachel. So thank you, everyone, for your really insightful presentations. And so I just want to start off with a pretty broad question that each of you may be able to speak to. And we've heard a lot about the timing on the panel today, and we've also heard a lot about readiness, physician readiness, readiness of the provider community, you know, and I want to throw in another aspect of this, which is the role of the Medicare beneficiaries. So could each of you speak a little bit to kind of what your assessment is of readiness to move towards this model? And I know there are activities that are happening to address that.
Well, briefly, I have a membership that goes from Hawaii to Maine, across the country, different regions. And it varies dramatically. I mean, I think we don't have Tims and Mass Generals everywhere. We have, you know, places like Maine where it is mostly rural practices, and they may or may not be paying attention. One of the things that I think did not really get discussed, but I think is also factoring into readiness, is there's a lot of interest in some of these new CMS programs. So CPC Plus, as an example, or some of the CJR. And that, in some ways, it's not clear how those will fit into some of the MACRA changes. So, and how can one be successful in multiple aligned programs? Most communities don't do randomized controlled trials and say, we'll do an episode here, we'll do an ACO there, we'll do a PCMH there. It's really bringing those efforts together for amplified impact and success. So I think we really need to think about how this plays out at the community level. So those who are trying to move forward can navigate the new rules. So again, there's a lot of variation, but there's also a lot of eagerness to really change things. I don't think the current system is working for anyone. So I think physicians and employers and communities are really ready to see some change.
So I would agree that the readiness is variable, in particular readiness for advanced APMs, as was noted, 90,000 or so clinicians probably are eligible for advanced or participating in advanced APM, so that is a minority. But let's look at the whole picture. It's readiness for MIPS plus APM. So certainly readiness for participation in an advanced APM and taking that downside risk, we know needs to grow over time and is not as broad as hopefully that it will be. So certainly for the first year, we understand that. I think, though, for MIPS, first of all, remember there's an opportunity for upside and downside. So I hear a lot, an assumption, I'll just take the 4% cut. But hey, if you're a really high-performing doc, you could certainly do better. We know that from 2014, about 62% of eligible clinicians participated in the PQRS program, right? And the PQRS program certainly has its flaws and its warts that we all know. But what I would say is, in order to get ready for 2017, the best thing a clinician can do, if they aren't already, is to participate in PQRS and meaningful use. Because under that program, clinicians can understand what it is they need to do to submit measures and look at registries and other vendors that they may be able to develop a partnership with to be able to submit measures. Again, I think there's a lot of probably you could say flaws within the current programs that we're trying to mitigate or remediate under MACRA, but nonetheless, that really is, I think, one very important way that folks can start to get ready for 2017. And I think it's important to also remember that the difference between what you have to do in 2016 if you do participate in PQRS and meaningful use and what you have to do in 2017 is not wildly different. The requirements for MIPS that we're proposing for 2017, we believe, will simplify and reduce burden. But in terms of the types of measures that are available and what you actually have to do to submit is not, a wholesale difference between the two. And then finally, I would say, if first of all, I think we have a lot of work on our plates, but that we share with a lot of folks like the specialty societies and the regional collaboratives and even the EHR vendors and registries, helping clinicians to get ready and helping them know this is even coming. That's a huge lift. It's something we're spending a lot of time on now at CMS. So I think for the next several months and well beyond that, of course, we need to spend a lot of effort educating, and helping clinicians to know about the program and to be able to participate, at least in MIPS in 2017.
Well, I guess I would just underscore what I take away from Kate's comment, which is you can look at it as the cup half empty or half full, but if you look at it as half full, 50% of docs are doing all of this already, but in a more cumbersome way. So that first year, it's more simplified, and all the docs that are in organized systems that have been doing this are actually going to experience a little relief from the process. So I think the consolidation and the simplification as the way into this got at least 50% of the docs in the country they're already ready, and they're already doing it. And that's a great place to start.
I guess maybe I don't have to turn on the mics, or maybe I just turn mine off. In any case, I would just say that I agree with what everyone else has said, but I'll point out that I'm worried about CMS and how they're going to get ready because, comments are due at the end of June, and they have to turn them all around, and the final rule has to be out, by November 1st in order to implement it on January 1st, and so they're going to get a lot of comments, and they're going to have a lot of work to do.
So Starbucks needs to move even closer to HHS. I just have a quick clarifying question on the point of education. Someone asked as far as the payment adjustments are concerned, I believe somebody already said this, but just as a clarification, it's not a hard 4 or 5%. It can be kind of a sliding scale. Is that correct? Mm-hmm.
That is exactly correct. So I will point out that if you don't report, or if you are at the 25th percentile below the threshold of the benchmark for the entire score, you get the full downward 4% adjustment that's written into the legislation. And then it will be essentially a sliding scale between that minus 4% and the plus 4%, with an opportunity for greater than 4%, particularly if you're a high-performing clinician. Because I didn't mention this, but there actually is a provision for $500 million a year for, I think, either 5 or 6 years to fund extra rewards for clinicians who are particularly high-performing as well.
Not to pile on to Kate, because we are worried, but I think the timing of that technical assistance contract is going to be really important. If that doesn't come out until October or November, and the performance year starts in 2017, it's just going to be more worrisome. So again, we need to see all of these things moving forward as quickly as possible.
Yes.
Thanks.
Yes.
Great. Looks like we have a question at the microphone. Please introduce yourself.
My name is Shala Madhani, and I'm with McDermott Plus Consulting. And I want to first of all thank everyone for these. It was really good to hear different perspectives in one forum, which you don't always get, and that's been helpful. I have a technical question that's come up with some providers we work with in terms of subsequent years, what will implications of what happens in 2019 and subsequent years. And in 2019, if you get a positive adjustment, and then in future years, when you're looking at resource use, will those providers who get the positive adjustment, will they be considered inherently more expensive, or is that sort of adjustment going to be normalized and taken into account?
When my thing is on here, it's a very dim light. That's an interesting question, I will say. It isn't just based upon, I mean, it depends, so it is part A and B costs. We would have to do an adjustment on the back end to account for their 4, 5, 6% upward adjustment so that we don't actually inadvertently penalize them because they got 106% reimbursement as opposed to 100% reimbursement.
Okay, so that is part of the plan, that it would be
If
normalized?
it's not, it will be. I would have to actually ask our technical experts if, I mean, that is a very good point, and I will bring that back, but there is no way we would ever want to penalize a doc in subsequent, I can just guarantee you that as a policy principle. We would never want to penalize a doc for being high performing.
Great, we've got a lot of questions. You guys have a lot of questions on these. So we've tried to group them so we can get through as many as we can. But let's touch on resources for providers, both in terms of the types of technical assistance, how kind of real-time site-specific technical assistance is going to be delivered, but then also to Tim's point of, you know, asking for folks to make an investment in technology and changing the way they deliver care 2 years before any payments or additional payments might be coming through. What do you have envisioned or some thoughts for helping clinicians get through that gap period?
So on the technical assistance, that can happen in a number of different ways. So like I mentioned before, we have the Transforming Clinical Practice Initiative, and right now, all of the awardees under that initiative are actively signing up practices, including, you know, solo practitioners, everything from solo practitioners to very large group practices. They're you know, signing agreements with them, and most of them have actually met the targets that we have set. So we're really excited about that. We're seeing a ton of interest out in the field because you know, and they're doing it through the lens of MACRA. When we actually did the TCPI, actually MACRA hadn't passed at that point when we first started putting out the request for proposals. So I do think that there's going to continue to be growth there. And then, as I mentioned before, what's in the legislation around the small practice technical assistance, you know, the law asks that we work with regional health collaboratives, regional extension centers. We also have actually a task in our QIO statement of work so that the QIOs can work with practitioners. So there's a lot out there, but it's not going to cover everybody, right? And so one of our strategies is to also partner, we're working through this now about how we can exactly do this, is to partner in a more informal way, not through us giving money kind of way, with, again, the specialty societies and the EHR vendors and the registries to help them be able to help their clients in being able to be successful. So we recognize we cannot do it all from Baltimore alone. There's no way that's ever going to be successful. We do have to finish the rule from Baltimore alone, that's true. But in terms of the technical assistance, there's a lot we are doing, but we need other you know, surrogates out there to help practices. Now, on the gap, you're talking about the 2-year gap that Tim mentioned, is that right? Okay. So that is, I think, an interesting problem. We did propose 2017 as the performance year to affect 2019 payment. If you have a year-long performance period that ends at the end of 2017, you'll be getting your feedback reports in mid-2018, so you actually know how you do within 6 to 9 months, but then your payment doesn't change until 2019. So I think we have some challenges here that some of it is absolutely CMS challenges that we have to figure out how to work through. But again, this is one of those that isn't just CMS alone. We have to work with providers, and I would say definitely third-party vendors, in particular registries and EHR vendors who do the submission of data on behalf of clinicians. Because let me just walk you quickly through the timeline. Your performance period is 1 year. In PQRS, we used to have a 6-month performance period that was available to people to choose if they wanted. 0.5% of clinicians chose that. And the feedback we always got is people felt like they really needed a year's worth of data in order to have a measure be reliable. Now, obviously, there's areas where people are getting 3 months worth of data to measure their performance, as Tim pointed out. So that may not, always hold true that you've got to have a year's worth of data, or there's a feeling that you need to have that. And then you have about a 3 to 4 month period of data submission. This is just the way it works now, right? Which typically actually does get extended at the request of the provider community. And then we have to calculate the measured data, and then give feedback reports, and typically that's been happening in about September. So once you look at that sort of whole timeline, then you got to think about, okay, where do I squeeze? But it's not just about squeezing, I don't think. It's about figuring out ways to be more efficient, maybe have more frequent rapid cycle submission of data. And so I think those are things that we do very much want to work through with the vendor community and the provider community, but it's going to require some shifts in behavior and also in process in order for us to get to a place where we're doing something like what Partners is doing. The government machine does not work as quickly as Partners Healthcare probably, but nonetheless, I think it's definitely a goal, and we would like to get to that point.
I'd just like to add one other piece that I haven't heard come up is the qualified entity network. There are 10 to, I think, 13 qualified entities, and there are new rules pending that would enable them to share feedback reports with providers. So multi-payer claims, actually all payer claims, to at least look at cost and resource utilization. And to the extent that they can then provide that information and those private reports for improvement, that might be another place to look for help.
We had a number of questions wanting to know how MACRA is going to affect fill in the blank, right? Okay, so so let's try to think about this in a cohesive way. So questions about behavioral health providers, which there's been a big push for, making sure that our behavioral health and mental health services are integrated into traditional healthcare delivery. So how we're integrating those types of providers, what this really means for new ways of new delivery models, such as telehealth and remote monitoring, and what does it mean for those folks? And then there are obviously physicians who are in situations and specialties such as like emergency medicine that they don't have as much control necessarily over either the cost or kind of the attribution issue of who's arriving on their doorstep. So I know that's a lot, but it's a couple of different buckets of different types of providers. But I would love all of your thoughts on obviously this move to kind of coordinating with the broader community and how you see this kind of impacting bringing in other types of providers and some specialty concerns.
So I'll just say a little bit, but I am actually very interested in others' thoughts about what the downstream impacts for these types of providers would be. So let me just start with, I could take all of these as one bucket, but there actually are some differences. So I think a couple of things just to point out that are in the proposed regulation. At CMS, we have a major emphasis in our quality strategy and everything we do around behavioral health, and particularly, so mental health and substance abuse, and particularly around how that gets integrated with clinical care, and what are the levers and incentives that we have to encourage that integration. Certainly there's a potential certainly for a future alternative payment model that is focused in that direction. There's not one that exists right now, other than, you could say, under an ACO-like structure that you may have some incentives there, but they're not directly related to that particular issue or to telehealth in particular. So I think we would be very, very interested in alternative payment model proposals that do have that either as an area of focus or at least as part of how value is defined as part of a model. So just to say something we would absolutely be very, very interested in. Under MIPS, there are some clinical practice improvement activities that we have proposed in our inventory that are related to exactly those two areas. What we're hoping to do in the future, by the way, in that category that's relevant here, is we right now do a call for quality measures every year where folks who are out there developing quality measures, mainly specialty societies, submit them to us for consideration for our programs. We want to do the exact same thing for clinical practice improvement activities, but we want to know that these are activities that are actually improving care or have value in some way. So I think there are opportunities going forward for folks to let us know what kind of innovative stuff they're doing with telehealth or behavioral health, clinical health integration. And we do actually have a particular category for around emergency care for clinical practice improvement activities as well. And I'm a practicing hospitalist. I absolutely understand the challenges of facility-based clinicians under this program. The comment that was made earlier by you, Ashley, around allowing clinicians to use hospital-based measures, that is absolutely our goal. We think that is a tremendous idea, and that the legislation allows us to do that. It's purely about setting up the operations and ability to do it. We're hoping to get to that in the second year. We think that's really important. But I'd love to hear what others think about what we could do in
Maybe
here.
I can jump in. A couple of thoughts on the behavioral health side. You know, there's been some strides recently to propose the sharing of that information. There's been kind of a wall through IT systems to share behavioral health and clinical health, and so there's been breaking down of those walls within the healthcare system, which is really helpful. But an ACO is not necessarily a healthcare system, so within the ACO, the various partners might not have access to that data, and that's really critical. Secondly, related to behavioral health is the opioid issue. And I don't drill down enough in the measures that are being chosen by doctors in the MIPS program. But on the hospital side, we have some concerns with our HCAP measures. And so I would just not want it to see replicated on this side, because our measures assess under the patient satisfaction program, whether a patient is basically pain-free is what they're asking, which is not the best way to set it up. You know, whether have your pain under control might be a better measure, because we've heard of doctors, so it must be in the physician side too, perhaps over-prescribing in order to make sure that they have their patient satisfaction scores up. So that might be one way to get at that issue. On the telehealth, I think that that's a great way, and I think that most of this is through the alternative payment models, and we've seen CMS really take great strides, and we appreciate it, to remove some of the telehealth barriers like the originating site fee, or the fact that it has to originate in a rural area with like the CJR demo, some of the BIPSI work and in the MSSP. So that's been really, really helpful. I don't have a good solution for the emergency medicine docs except to allow them to use the hospital reporting measures.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also an attorney. I practiced medicine at Fort Belvoir and at Bethesda Naval Hospital until 2007, when I retired. I am delighted that I'm 69 and will not have to do any of this. Are you concerned? I mean, I understand how much enthusiasm you're hearing from doctors. I don't know who you're talking to. It's not the same people I talk to. Are you concerned that doctors are going to spend more time worrying about making their performance measures on which their income depends than taking care of their patients, spending time with them, talking to them, finding out what they want? You can't reflect that in the electronic health record very much. But if your income depends on getting 100 points on MIPS, you might not have a lot of mental effort left over to take care of your patients. And people who want to take care of patients may go into specialties. This really crimps primary care. Cardiologists, not so much. I thought someone needed to say it because nobody has.
Yeah, so we've been doing sort of listening sessions across the country, actually, to hear, how clinicians are reacting to not only MACRA if they know about it, but our current programs, which, again, are very similar in terms of the kinds of things that clinicians are held accountable for. And we've absolutely heard everything that you've been saying. People feel like this takes away from time, particularly we've heard about meaningful use, but that it takes away time that they spend with their patients, and that really there's just such a tremendous need to reduce the burden. I think people are mostly believe that it makes sense to pay based upon the quality of care that is provided. I will tell you, we haven't heard a whole lot of pushback about that in concept, that makes a lot of sense. But it's the devil's in the details and the how of how you do it. And there's no doubt that the way it's been done.
And how you define quality.
Huh?
I mean, making sure
Sure.
that everybody got their tetanus shot in 2,000 patients is not a very important measure.
Yep, I agree. That
Because
probably
7
isn't.
people get tetanus a year in this country.
Yep, I don't think we have a measure of that, but I think that you're
But
right, that
someone
would
did
not
that
be.
for a performance improvement project. It was published.
Right, yeah. Well, we also do rely on the clinician world to suggest measures to us, and many of the specialty societies, in fact, most of the measures that are in our program are developed by physicians and are developed by physician societies. based upon what they believe is important to them and to their patients. I think that there's definitely a need to move to better measures that are easily captured as part of workflow as opposed to this extra on top of what I'm doing kind of thing. We are not there yet. There's no question about that. So your point is very well taken. I thank you for that.
So I think Tim wants to jump in to this question, but just quickly before he does, I just want to remind folks we have about 12 minutes left in this session. If you do have to leave, please fill out an evaluation before you do. Tim.
Great. Well, thanks for your comments. And I think you probably articulated it better than I did, but I was trying to make the points that you just made in my comments. You know, it's about speed, the pace. We can only, all of us can only tolerate so much change so quickly, and done in a managed way that respects the work, the professional work of the people who have to deliver the care, this can be enormously beneficial to the entire population of the United States, including the delivery workforce, the physicians and nurses. But the difference between figuring out what the right pace is, there's going to be a spectrum. And CMS has a very, very challenging job because there are people who are ready and doing this already, and they're ready for more. And there are people who haven't even started doing this. And so figuring out what the overall pace is, that is part of the what I believe, if I were to interpret what Kate was saying, building in the flexibility. Because it's that flexibility that creates complexity. The complexity makes it much more difficult to understand, but underneath that complexity, it does include the ability to pursue this avenue at a pace that is appropriate for your organization. So I would just say that would be my take. I want to go back because it's deeply important to me about the mental health issue and the inclusion of mental health. It is a really, really big problem in this country that started actually because of the payment system. When the payers started paying for mental health care separately, it created an entirely different silo of care, which is the mental health delivery system, and it disintegrated it with the rest of the delivery system. There's an exciting opportunity underneath this, the current proposed payment models. And I know of actually dozens of people who live in the different silos, mostly primary care and mental health care, that are working on proposals to submit for advanced APMs to reintegrate those things. And of the various problems in our healthcare system that this has the potential to productively address, I would say this is the mental health integration is got to be among the top three potential. So this one it's worth it just if we made some progress on that thing alone.
That's great. That tees up our next question. We've been talking about a lot about, impacts on providers and impacts on systems. Kind of implied in there is that there's going to be some benefits and impacts on patients. But if we can, think for a second and just have a conversation about, what you see as the expected impact on patient experience and even health outcomes. And you started with mental health and behavioral health, and certainly integrating those may be a start. But if each of you wanted to weigh in on, what this has the potential to do for patient experience and patient outcomes.
I think that is a critically important question, and one of the things that I've been a bit concerned about is really just thinking of measures from a provider perspective. And I know nobody's trying to do that, but sometimes there are different priorities from patients and from employers. And so really maintaining that multi-stakeholder focus, what matters to each of them, is going to be very important in measurement. I think in terms of longer-term outcomes for patients, to the extent that we are incenting patient-centered medical homes, as an example, we have the potential for patients to have more time with their providers, more flexibility in how they're engaged and treated, and connections across the system as opposed to sort of being left to navigate it on their own as teams change. So there are a lot, you get full credit if you're a patient-centered medical home, or you will have incentives to be participating in CPC+. So there are incentives to really strengthen primary care that I think could have very positive outcomes for patients.
There are requirements throughout the law that focuses on improved patient health, improved outcomes, improved patient experience. I mean, it's called out explicitly in the law. So clearly that was the intent and the purpose of this, is to really result in better patient outcomes and patient experience. And so certainly as we transition over time, the incentives that are built in for transitioning to advanced alternative payment models, which pays clinicians in a way that sort of frees them up from the barriers of the fee-for-service system to directly incentivize activities that include engaging directly with patients, including them in shared decision-making, coordinating care with all the other providers on the team, developing care teams that include a variety of different provider types, including things like community health workers and so forth. All of those things potentially are incentivized under alternative payment structures. So I think that that is certainly a very possible outcome. Of course, the devil is in the details and how we implement it and how others pick up on it. So, but I think that's exactly right, that is where the goal is. I think under MIPS, because you're still built upon the fee-for-service system, there are certainly provisions related to holding providers accountable for patient experience and patient outcomes and the good work they do to try to improve care for patients. But I do think that the biggest bang for the buck is probably in the different structures of payment that incentivize very directly those types of activities.
So the quality of care delivered in the United States, even on tetanus, is unacceptably variable. And a fundamental aspect of having measures across, we can argue about priorities, clinicians can argue about priorities. The fact is that in every practice in the United States, we should not let the patient leave unless, if they're due for some preventive screening test, we should raise that, right? If they're due for a flu shot, we should raise that with them. If their hemoglobin A1C is 8.9, we should be working to reduce that to below 8, right? It is through the registry systems that we document that we're actually delivering on that promise. When we've implemented our registry systems, slowly, carefully, with the physicians and nurses, we can document that we have dramatically improved across all our patients the health of those patients, not just measures of healthcare delivery, but the actual health of those patients. And the proof is in, as Ashley said, the vital signs report. That recommends the measurement of certain health indicators across populations: primary prevention, secondary prevention, cancer screening, right? If we can do those three across the major chronic illnesses well, which is what the measures are that are in the measure set at MIPS, if we can do that systematically across the United States, we will improve the health of the people in the United States.
I think the other panelists said it incredibly well. I'm in the same camp that I think that this will benefit the beneficiaries, because you really are shifting things away from doing more, and more care is not necessarily better care, to doing the right care and strengthening primary care. And for those beneficiaries that are in alternative payment models, those are really the ones, the advanced APMs, that are going to be able to do kind of the hot spotting and the trends, and able to really help control that train wreck of a patient who has multiple chronic morbidities or chronic conditions. So I think it will be very good for the beneficiaries in the long term.
Great. This, I think, is going to be our last question. We've got a lot of questions that we didn't get to, and we really tried to group them and get to as many as we can. So for those that we didn't address, we will follow up with our speakers and get that feedback back to you. And I hesitate to even ask this, given how bipartisan and cooperative and collaborative this whole conversation has been, and the legislation has in fact been. But we are in an election year, and there are a lot of questions and a lot of uncertainty, and we've gotten a lot of comments and questions here on the table. So your thoughts about what the uncertainty surrounding the election and in either situation, we're going to have a new administration, and what that does and kind of how this positions the implementation and the rollout of these changes that will certainly be happening over a number of years during this same time. So for folks that might want to weigh in on that, that'd be great. We're going to start at this end with Ashley.
Well, you know that the American Hospital Association will work with whatever candidate in their administration takes effect. And, you know, I think that they're not going to roll back this MACRA. I really don't. You might be asking a broader question about the ACA in general, but I'm not going to go there. I think that it's just MACRA, and I don't think that they're going to roll this back. I think that there's been too much focused effort given that the bipartisanness of the bill to move it forward, because I'm not hearing, while solo practitioners might be scared, I'm not hearing a lot of pushback. I think everyone thinks that this is the best way to help control the rising healthcare costs in the country, and a way to improve care efficiency and care coordination.
You know, I really don't have a basis for addressing your question. The problems that MACRA is intended to address are fundamental and have nothing to do with politics. Of course, the implementation of any rule has a lot to do with politics. And so how it goes forward, this is less about the problems and about the concepts in MACRA and more about the implementation. And, you know, who will be more responsive to the constituents and which constituents' voices will be heard louder is, you know, a political analyst would be better positioned to answer that.
I mean, this is one of the highest priorities for CMS right now. It may be at the very top, or certainly close to the very top. It is hard for me to imagine, because of what Tim just said about its fundamental nature, that it wouldn't continue to be a top priority for whatever new administrator or administration comes in. At CMS, we will, of course, implement the laws that we are given to implement, no matter what. I certainly think over time, like with anything else, that there could be legislative tweaks, big or small, depending upon exactly that, the implementation and the response to that implementation. So I would certainly anticipate that. I don't have a real sense, I'll be honest, for how partisan that may or may not be, because this feels so much like a nonpartisan topic area, but that's just sort of my take.
I think the fact is we have to change the system. It simply is not sustainable in terms of cost or quality. So whoever is in the administration, the challenges aren't going to go away. And to go to Tim's point, I mean, we're talking about fundamental changes. I don't think they're partisan. I think they're very pragmatic. We're talking about how to make a market work. We're talking about how to engage patients differently. These are really pragmatic issues that we all have to wrestle with. So I think it's not going anywhere. I think we've got a lot of work to do, and I think it's going to take all of us to make it successful.
Great. So please join us in thanking our panelists.
And fill out your blue evaluation form, please. Have a great afternoon.